we move on to the vascular changes resulting from burn injuries. So there are so many pathophysiological abnormalities or mechanisms or negative feedback mechanisms that usually happen as a response to the burn injury. So for the vascular changes, remember vasculars, your arteries, your veins, your capillaries, these are the likely system in the body which is affected because of the burn injury. So the first one on the list is circulatory disruption. Actually occurs at the burn site immediately after a burn injury, as with any type of trauma. That is what is the usual response of the body. And then because there is circulatory disruption, blood flow decreases due to the occluded blood vessels. So because there's the trauma of the exposure of the burn, it destroys some of your blood vessels. It occludes some of your blood vessels. Then therefore the blood flow decreases, and with that blood flow decreases, there's possible damage also of your macrophages. Okay, there's possible damage of your macrophages within the tissue, which, you know, your macrophages release chemicals. Okay, stimulate the release of chemicals that cause constriction of the vessels. Remember your concept about inflammatory response. This is actually it. Because of the trauma in your blood vessels, you have a release of system of cytokines, your histamines, okay, which causes constriction of the vessels. And then also at the same time, because there is destruction or the occlusion of your blood flow and it is continuous, blood vessel thrombosis may actually occur. And with this, the result would be your necrosis. There would be likely death in your vascular compartment, death in your blood vessels. Now, because of this death, what happens is that the initial vasoconstriction, okay, happens. But gradually, the body is going to respond as an effect of that vasoconstriction. What happens next is that your vascular compartment will start dilating because of the continuous release of your cytokines and your histamines. Now, the blood vessels dilate, okay? These very weak blood vessels have started dilating now. And then, because it is dilating, we have your capillary opening up and then leaking the fluid into your interstitial spaces. Remember that from the vascular compartment, all of those plasma, all of the blood, all of the fluids are actually inside your blood vessels. But because of the trauma that's happening there, and then the chemicals that are actually released into your system, causing your initial vasoconstriction and then your dilatation, blood vessels become dilated and fluid is leaked out into your interstitial spaces, thereby causing you to have your third space syndrome, or what we call your capillary leak syndrome. And because of this, okay, there is going to be a decrease of blood volume and blood pressure because there's not much plasma or fluid inside your blood compartment. Okay, and this one usually occurs within the first 12 hours after the burn episode and can continue up to 36 hours. I don't know if you could understand, but I think this is a much better example or a much better visualization of what I'm talking about. So fluid spacing, okay? Remember the earlier concept was about third spacing. What is fluid spacing? This is fluid spacing. For the first spacing, it's your normal. Your fluids are inside your intravascular compartment minding their own business. However, when you have your second spacing, there is a leak of some of those fluid into your interstitial spaces, causing you to have your edema. This is a classic example of a pitting edema. Okay? Clients, remember your pressures, your oncotic pressure and your hydrostatic pressure. Okay? For your second spacing edema, this is it. This is one of a classic example. And then for third spacing, where it becomes more severe, I mean, the fluids go to areas which they are not wanted or which they are not required, then therefore this is your third spacing, the severe type of fluid spacing. So, for that matter, we have here a classic example of a third space syndrome wherein you have your ascites. And likely, you can see later on in our pictures, we have your burn edema. Okay? Edema, or the inflammatory reaction or response with the fluid going to that specific area as a result of your burn injury. Now, as a review of our fluid and electrolytes, I think I have not discussed so much on that because we had so many restraints in the past months. So, I would like to reiterate again how the capillary leak of fluids happen. So, this part here, okay, this is your vascular compartment. This part here is your arterial end, while this one is your venous end. And this area here, you just imagine that this is where your capillaries are. In this space here and then this space here. Now, your hydrostatic pressure, okay, is around here in your arterial end. Now, your hydrostatic pressure, this is, by the way, a review of your hydrostatic and your osmotic pressure so that you could understand how your fluid leaks out into your interstitial fluid, okay? So, let's review it this time. So, your hydrostatic pressure allows your fluid or your plasma, okay, some parts of your plasma from your intravascular compartment. Intra means inside your blood vessels, okay, this part here. Because the hydrostatic pressure is actually very high, some of your fluids are actually leaked out. This is your capillary wall, and it actually is permeable in nature. In normal case scenario, okay, just slightly permeable. Hydrostatic pressure has high pressure to allow the fluid to be leaked out. Okay, to be leaked out into this area. And this is lacking, by the way, lacking in drawing. So I need to write something. So we have here, okay, these are your cells outside of your intravascular compartment. So these are your cells here. These are your tissue. You have your collagen here. Okay. So yes, this is what we call your interstitial spaces, where you have your tissues and your cells here. Now your fluid leaks out into your interstitial spaces. That's why we call it your interstitial fluid, and that's the fluid in between your cells and in between your tissues, along with the collagen there. Okay? Naturally, we also have a counter pressure, which does not allow an abnormal leaking out of your fluid into your interstitial spaces. That's why in this point, from this point on, nearing your venous end, we also have what we call your osmotic pressure. Or, in some case scenario, you call it your oncotic pressure. Okay? Oncotic. Or, we call it your colloid. I'm sorry about my handwriting. It's really bad. Okay? That's your colloid oncotic pressure. Your colloid oncotic pressure has a high affinity to what we call your proteins. Because colloid is a protein, right? Okay? Albumin is a protein. All of your plasma proteins, this is guided by your plasma protein. Now, if you can still remember in your biochemistry, what does your protein do when it comes to maintaining your colloid oncotic pressure? It allows, okay, or this is like your guard. This is like your guard in not allowing the unnecessary seepage or leakage out of your fluids into your interstitial spaces. This osmotic pressure allows the fluid from outside to go back inside, or just even maintain, okay, even maintain the fluid inside, okay? It does not allow unnecessary leakage of your fluid. So, if that is the case, these two pressures are very, very important in the regulation of your fluid in your intravascular compartment. Now, what happens when we have your burns? Okay? Technically, there are so many chemicals that are released here. And then, because there is dilatation of your capillaries, okay, that minimal dilation or that minimal capillary permeability becomes so huge, okay, that all or most of the fluids in your intravascular compartment goes out. Okay? What happens is that the fluid which is supposed to be here, okay, most of them go out. This is what happens in burns. And since the fluid here has slightly dropped, it will also mean that there is decreased blood volume in your intravascular compartment. and because there is decrease in blood volume in the intravascular compartment, that would also mean that there will be a drop also in your blood pressure. Where did the fluid volume go also? It went out here in your interstitial spaces. It went out here and became your interstitial fluid. And I've mentioned it's in between your tissues and in between your spaces. So if you're going to look at a client who has your burn injury and is suffering from third spacing, everything is edematous. If you're familiar with the animation, Japanese animation, Mojako, it's a huge guy, which is, how do you call this one? Is swollen all over from head to toe. Okay, so that is a likely example of what it is to have third spacing. We have fluids going to areas which they are not wanted. Okay, so that's why you have fluid loss. Where did the fluid loss happen? The fluid loss happened here in your intravascular compartment because they went out to the area, okay, which they are not required. Okay, so that is, see, this is an example of a client who is suffering from burn edema. Okay, burn edema. Next, so we have also another look at the patient there. So it's very difficult for you to manage a client who has your third spacing because likely most of the tissues are swollen and you cannot do invasive procedure at that until it subsides. So inflammatory process, systemic inflammatory process actually happens here. Okay, so again, aside from the vascular problems that might happen, we also have your fluid imbalances. So it occurs as a result of fluid shift and cell damage. So you have your hypovolemia, you have your metabolic acidosis, you have your hyperkalemia. Hyperkalemia results because the cell, remember PISO, the concept of PISO, P-I-S-O, potassium inside. Okay, I'm gonna write, maybe change, okay, PISO. Okay, potassium inside, sodium outside. Now, if you have massive tissue destruction caused by the trauma of your burn injury, then therefore, all of those potassium from your cell will actually leak out. Okay? This is your cell and you have your K here. And then when this one is destroyed, where would the potassium go? Outside. Okay? Outside your cell. Where would it likely also go? You have areas in your interstitial spaces. You have areas also might happen even in your intravascular compartment, because I'm not just talking about your cells, epidermal cells, or your other cells, but I'm also talking about your RBCs, which is likely also a cell. So that also has your potassium. Okay, and where do the RBCs travel? It's in your intravascular compartment. So technically, when you have burns, okay, this is one of your manifestations. Hyperkalemia, found in your laboratory results. You also have your hyponatremia. You lack already the solutes of your sodium. Okay? And you also have your hypoproteinuria. That's why there is a drop in your colloid oncotic pressure. Colloid oncotic pressure. I'm so sorry, but I would really like to emphasize on this one. Colloid oncotic pressure. And then we have your hemoconcentration. Hemoconcentration means there is elevated blood osmolarity. Why is that? Because there's not enough fluid in your intravascular compartment. Hematocrit is the percentage of your RBCs in the total fluid volume or your blood volume. Now, the problem here is now, because there is less of your fluid in your intravascular compartment, there is now a higher percentage of your RBCs in your intravascular compartment. So, the more solutes in this case will be your RBC, the more solutes there is, the higher is your osmolarity. So, we call it your hemoconcentration. And therefore, since there are so many solutes, likely you will have your dehydration. Okay? Sobrang dami yung solutes natin. And then, when we're done with your fluid imbalances, we go to your cardiovascular system. So, this is a review already of your NCO 103 discussion about your shock. So, because there is massive fluid shift from your intracellular and intravascular compartment into your interstitial spaces. I have mentioned that one already. Okay. In 24 to 36 hours of your injury, there would be problem of your direct cell wall integrity loss. So, because I've mentioned there is already less of your fluid in your intravascular compartment, and because there is less fluid, that means there is less blood volume, and then therefore, what happens there? You have a drop in your blood pressure. Okay? Drop in your blood pressure. And because there is less blood volume, less blood pressure, therefore, it follows also that your cardiac output is going to be affected. Okay? Less cardiac output means less tissue perfusion because it would not reach most of your tissues or your cells. And then another thing is that since the proteins and your sodium escape, remember, you have very large holes in your capillary. So, the proteins and sodium escape into your interstitial spaces. What happens is that potassium increases and then will decrease as burn shock results. So, this is likely what happens when you have your hypovolemic shock. Okay? Myocardial dysfunction, I've mentioned, since the heart is unable to pump out enough blood volume and then reach to other tissues, there would be, inflammatory reaction also to your myocardial tissues, and then you will have ventricular fibrillation, you will have dysrhythmias, likely, worst case scenario, you will have cardiac arrest and vascular compromise. And since also we're talking about systemic involvement of your cardiovascular system in a burn injury, yes, I mentioned, you will have edema, okay, as a result of that fluid loss in your intravascular compartment and your compartment syndrome. Remember, I talked about your fasciotomy, okay? My apologies, really, but I really want to emphasize on this one. Okay, this is your fasciotomy when the tissues that are affected in your burn injury, actually your compartment syndrome does not necessarily happen only in your burn. It also happens when you have your fracture. Okay, so in this particular scenario, I'd like to explain your compartment syndrome as, an effect of the fluid third spacing that's happening there. And then because there is your edematous, systemic edematous generalized edema that's happening in that specific area, everything is just swollen. And because there is continuous swelling, there is also obstruction of your blood flow. Okay? And since there is obstruction of your blood flow, perfusion to your tissues cannot actually happen. And because there is less tissue perfusion, technically, there might be possibilities of your necrosis. And you don't want that to happen. That's why we need to make a slice. As I've shown to you, the third degree burn, wherein there is your perpendicular and vertical slices there in your torso. And then it allows for breathing area of your blood circulation system to actually flow. And then, appropriate distribution of your nourishment can actually happen this time. But when you have your compartment syndrome, everything is like in a fist or in a vice. There's no room for breathing for your tissues who are obstructed and occluded of your oxygenation. Okay? Next, we have your CURLING'S ulcer, one of the many complications with what's going to happen in burn injury. So, we also call your CURLING'S ulcer as your acute ulcerative gastroduodenal disease. It occurs within 24 hours after burn. So, why would we even think about digestive system affectation when the burn is likely very, very far from your GI system? Come to think of it, we have discussions about stress before, right, in NCM 103. So, when we are talking about your CURLING'S ulcer, this is due to the cortisol increase, okay, caused by the very stressful, major stress event that's happening to your patient. And aside from that one, you also have damages to your gastrointestinal system caused by reduced GI blood flow and mucosal damage. Okay? Especially if there is your GI tract affectation directly of your burn injury. So, in this particular scenario, as a nurse, it's very important for you to watch for sudden drop in hemoglobin, because you are going to assume that since there is mucosal damage, see this part here? There is mucosal damage, okay? There might be GI injury, GI bleeding that's gonna happen, okay? So, what is the treatment for this? You need to treat it with your H2 blocker. And then you have your cytoprotective agent. Okay? What are examples of your H2 blocker? Can you remember? Guys? Pharmacology. You can remember your H2 blocker. So, H2 antagonists. Okay? And also your cytoprotective agent. Remember, I mentioned that once. Okay, you review on your notes and then answer that question. What's your H2 blocker examples and your cytoprotective agent for your GI problems? Okay, and then we might be able to provide enteral nutrition, maybe through, yes, TPN. It's your TPN. We call it your TPN, parenteral nutrition, versus your enteral nutrition through your NGT. Okay, next. So we have here phases of burn injury. So I think this one was given as a homework for you guys. I am not sure if you have read this one really well, because I made you do a concept map for your burn injury. So we have here your emergent phase, your acute phase, and your rehabilitative phase. Now, for each of these phases, there are so many, again, physiological mechanisms that come into play for each particular phase. So, let's start with your emergent phase. Let's have first the overview. So, phases of management of burn injury. For the emergent phase, it usually happens and begins at the time of your injury. The time duration between 36 to 48 hours. So, within 1 to 2 days. Okay, management. What is your management? Prevent hypovolemia, because the first thing that usually happens there is your fluid spacing, and then your third spacing or your fluid shifting. Okay, and then this would likely cause your edema and shock to happen. Okay, next we have your acute phase. Begins when patients hemodynamically become stable. There's an attempt of the body to make the patient stable. So capillary permeability is restored. However, because there is attempt for restoration, diuresis begins, because as an effect of the fluid shifting that's happening there. So the diuresis means massive diuresis. So 48 to 72 hours after the time of injury, this is the duration of your acute phase. Management. The goal of this stage is to prevent your infection, because I've mentioned infection usually sets in at 72 hours. Sometimes in unlucky clients, it comes in too early. Okay, so provide metabolic support, because there will be problems about metabolic alkalosis or acidosis for that matter, and then wound care. Okay, because the client is already hemodynamically stable, however, there is problems with your impaired tissue integrity. And then you also have to do your wound cleaning. I'm looking for, yes, this part here. And then your restorative therapy. Continue until wound closes. So this is your acute phase. This is rehab, letter B. Oops, letter B. Okay. Rehabilitative phase. Recovery represents the final care of burn injury and overlaps from your acute phase and extends beyond hospitalization. So the rehabilitative phase takes longer. And as a nurse, it's important that the management are designed for maximal function and emotional recovery. You know how stressful it is to have burns, and then the after effects of that injury would be for lifetime. Okay, especially if none of these managements were not done during the acute and emergent phase. So we must be there to support our client. Okay, so wound healing is there. Okay, it will take time. Remember our wound healing duration. We also have your physical strength, increase of physical strength. That's one of the goals, and provision of your emotional support. Okay, especially for those who have your third degree burns, and then you have affectation in your ADLs. Okay? Next, so let's go to the first phase. I've mentioned emergent phase. These are the pathophysiological mechanisms that usually occur. Problems would be for fluid loss. You have your edema. You have your reduced blood flow. Technically about fluid problems and electrolyte imbalances. So what are your goal? Secure airway, support circulation by having your, we call it your fluid resuscitation. Okay? Fluid replacement. Because the problem is you're losing fluid in this phase. Keep client comfortable with analgesics because it's very painful. Prevent infection through wound care. Maintain body temperature because, you know, a loss of your skin's capabilities for thermoregulation is not there anymore. So you provide and maintain body temperature and provide emotional support. So the manifestations, again, aside from the fluids, you have your pulmonary manifestations. Respiratory problems secondary to inhalation may occur, okay, during the emergent phase. So as a nurse, it's important that you assess your mouth, your nose, your pharynx, burns on the lips, the face, ears, neck, eyelids, the eyebrows, and eyelashes. These are indicators of your inhalation injury. If you're going to look at it, anything that happens on your face, that would mean there is a respiratory involvement already, or there are indications of inhalation injury. And what did I say about respiratory involvement when it comes to burns? It is considered as critical. Okay, so you also need to see respiratory pattern changes, and if the client's voice has become very hoarse, there is a brassy cough. So again, that's inhalation injury of burn, and then of burn episode. You also have difficulty swallowing, dysphagia. You have your expiratory sounds such as your wheezing, your crowing, and your stridor. So all of these are again manifestations that okay, something is wrong with the client, and this needs to be a red flag that needs to be managed immediately. Again, manifestations aside from that one is you have upper airway edema. The client is unable to breathe. There is problems in your trachea, or there's involvement in your trachea and your main stem bronchi. If wheezes disappear, this indicates impending airway obstruction. Remember how fast inflammatory responses actually happen. So, as a nurse, you are going to be on standby here, especially if, again, you have inhalation injury of a burn episode. So, intubation, it's a medical emergency. If the trachea and then the upper airway is already occluded, you are going to lose that battle for your patient. So stand by, immediately stand by for your intubation. Next, we have your cardiovascular manifestations. So cardiovascular signs and symptoms will begin immediately because it likely is associated with your shock. Remember, fluid loss, a drop in fluid loss, with your fluid loss, you will have a drop in your blood volume, and then therefore continuing to your shock. So shock is a common cause of death in the emergent phase. So as a nurse, it's important that you obtain a baseline ECG because there might be cardiovascular shock, cardiogenic shock that's going to happen there. Monitor for your edema, measure your CVPs, and then you do your blood pressure taking, capillary refill, and your pulse oximeter. These are very basic tasks of a nurse, and we don't neglect that. Okay, each monitoring is equally important, especially if we are going to extend the lifeline of our client. Next, we have your renal manifestations. So changes in your renal function are related to decreased renal blood flow. Remember, one of the most self-sacrificing organ in our body is your kidneys. And considering that in the cardiovascular affectation, there is already a decrease in your blood volume. And then because there is decrease in blood volume, there is also a decrease in your cardiac output. And when there is a decrease in cardiac output, what organ likely suffers there is your kidneys, because nothing reaches your kidney anymore. And because there are changes in your renal function, there is also problems in the distribution of your blood and nourishment to your kidney parts or your anatomy. And then this is likely going to affect the kidney's capabilities, okay, the kidney's function. This is because there is a decreased renal blood flow. So, likewise, what happens here is that when you are going to check your client's laboratories, your urine is usually highly concentrated. Why? Dehydration. There's an increased osmolality that's happening there. then the client is suffering from high specific gravity there because there's not much fluid in your circulation. Anong natira doon? What remains in your intravascular compartment are your solutes, are your very high hematocrit. Okay? So urine output is also decreased because there's not enough blood going to your kidneys. And if there's not enough blood going to your kidneys, what will the kidney create? How will the kidney create enough urine, right? So there's actually no urine output, and this is a negative feedback mechanism of the kidney to protect itself. So urine output is decreased during the first 24 hours of the emergent phase. So that is why it's very important as a nurse that fluid resuscitation should be initiated immediately. Okay? It's very important because again, blood loss, I mean not just blood loss, but fluid loss is a big problem here. So if there is a lack in fluid, what do? You give what is missing. So fluid resuscitation is provided at a rate needed to maintain adult urine output, and the normal urine output is 30 to 60 cc per hour. So again, since we are talking about your renal manifestations here, it is important that we also have to check your laboratories. Check if the kidneys is still working or if there is acute renal failure that's happening there. So, as a nurse, we are going to check the measurement of your BO and your blood urea nitrogen, your creatinine, and your sodium levels. Okay, that is just in your emergent phase. So many is happening in your emergent phase. And then we have your GI manifestation. I think this is where your CURLING'S ulcer is likely going to be manifested as a result of your sympathetic stimulation. Remember, there's your sympathetic stimulation during the emergent phase, causing you a decrease. Remember, if everything goes up, your blood pressure, your PR, your RR, etc., sympathetic stimulation would actually make a slowing down of the function of your GI. Okay, it's inversely proportional. Remember your SNS versus your PNS. Okay, SNS is fight or your flight, and your PNS is your rest and digest. Now, if your sympathetic stimulation, if your SNS is stimulated, what happens is that your GI and your motility tasks are going to be slowed down, extremely reduced. And then because this is a severe situation, the burn injury is a severe situation, technically that a reduction would likely lead to paralytic ileus. Totally stop. Your peristalsis just totally stops. And as a nurse, it's very important that we need to check the response of your GI system. So, we need to auscultate the abdomen and to assess your bowel sounds, which might likely be reduced. And then you also have to monitor for your nausea and your vomiting and your abdominal distension. Okay, so clients with burns of 25% of your total body surface area and who are intubated are generally on NGT to prevent aspiration and removal of gastric secretions. Obviously, the client would be unable to, orally ingest food because there is already problems with your GI tract. So in this case here, NGT is a likely order of the doctor to facilitate still the nutrition and the nourishment of the patient with a burn injury. Infusion of IV fluid is needed to maintain sufficient volume for normal cardiac output. I have explained this one earlier. Clients with burns involving 15 to 20% of the TBSA require IV fluid. Okay? I will show to you later how this one is very, very significant. Okay? And then the purpose is to prevent shock by maintaining adequate circulating blood volume. What is lost here is your fluid. Therefore, if you lose your fluid, you're going to lose your appropriate blood volume, and then you're going to end up with shock, and you don't want that to happen. Therefore, you are going to correct that by providing adequate circulating blood fluid volume through your fluid resuscitation or through your fluid replacement therapy. Okay? Severe burn requires large fluid loads. You are not going to be shocked when I say that the doctor will order around 2,000 ml to be given to your client in 8 hours. That is a very, very common order, especially that you're losing a lot of your fluid. So don't be shocked during your computation that you can have as much as that. Okay? Next. Again, this is your IV fluid therapy. Fluid replacement formulas are calculated from the time of injury and not from the time of arrival at the hospital. So it is very important that whenever you are going to manage a client who has your burn injuries, extensive burn injury, which requires your fluid resuscitation or your fluid replacement, please ask the time of the burn that happened to the client, okay? So that you can compute fairly well how much you need to administer to your patient, okay? Diuretics should not be given to increase urine output. No, because you're already losing fluid. If you're going to give diuretics, you're only going to add insult to injury. You don't want that to happen, okay? Change the amount and rate of fluid administration, okay, depending on the doctor's order, depending also on the computation. So diuretics do not increase cardiac output. Nope, not in this case. They actually decrease circulating blood volume and cardiac output by pulling fluid from the circulating blood volume to enhance diuresis. Ano ibig sabihin nito? The diuretics will pull the fluid that is supposed to continue circulating in your body and become your urine. You don't want the client to, excrete unnecessary fluids that the body needs. As much as possible, we need to maintain the fluids inside because we are already losing much of the fluid, okay? So that is for your emergent phase. In the acute phase, these are the things that happen. So, I've mentioned earlier, for acute phase, it lasts until wound closure is complete. The care is directed towards continued assessment, you do your proper monitoring of your client, and maintenance of the cardiovascular and respiratory system, because it's also during this phase wherein pneumonia sets in, your infection sets in. Remember, 48 to 72 hours. Okay? Pneumonia is a concern, especially if the client has problems with your respiratory failure requiring your mechanical ventilation. And infection, okay, the protocol there is to provide, especially that we have your impaired tissue integrity, the protocol there to prevent your infection from happening is to have your silver sulfadiazine cream and ointment applied to burn areas, okay? And then also you must have your tetanus toxoid shots, okay? Weigh patient daily and compare to pre-burn weight, because this is where we see how the client how the client's body has managed the fluid loss, okay? The fluid loss. Next, so nursing diagnosis for the acute phase. Yes, I've mentioned impaired skin integrity because it's where your wound closure usually happens now. Risk for infection, because I've mentioned infection set in usually in the span of 48 to 72 hours. Imbalanced nutrition, yes, because the client will be unable to eat normally and then ingest orally your food. Impaired physical mobility, because your client will be likely bedridden if the client has your severe burns. And disturbed body image, yes, because there is your manifestation of your wounds, okay? So these are your nursing diagnosis. And then for your last phase of your burn injury, you have your rehabilitative phase. Usually starts at the time of admission, but, okay, yes, because rehabilitation usually starts at the time of admission, but technically it begins with wound closure. That's, superimposing in your acute phase, and ends when the client returns to the highest possible level of functioning. So, in some other scenarios, this might take years and years until the client becomes fully rehabilitated of your burn injury. And in this specific phase, as nurses, we need to provide psychosocial support. We also need to teach the significant others to provide assistance, psychological and emotional assistance to our patient. We need to also assess your home environment, how it can help and contribute to the rehabilitation of the client. Financial resources, we could offer that. Financial resources for our client, medical equipment, prosthetic rehab, if there are problems with your contractures or if there is your loss of limb as a result of your burn injury. Another thing is that I've mentioned health teaching is one of our primary responsibilities as nurses. We need to do education on infection control measures, okay? Your following and strict drug regimen for our patient, follow-up appointment, and comfort measures for our patient, okay? So we also have here burns in infants and children. This should have been in the previous slide, but anyway, burns in infants and children is likely different from the adults that I have discussed earlier. So critical burns is considered as such for infants and children if you have full thickness burns covering more than 20% of your BSA. And then you also have burns involving your hands, feet, face, upper airway, your respiratory tract, and your genitalia. Moderate burns is associated with partial thickness burns of 10 to 20%. In the adults, it's 10 to 15%, right? And then it becomes minor burns if there are partial thickness burns of less than 10% of your body surface area. Okay, this is your major burn injury. I have likely discussed this one already. In the integumentary area, you have your skin loss, you have your sensory loss, and then therefore, because the skin is destroyed, you will have drop in your body temperature. Thermoregulation is not functioning as appropriately as it should be. And then you also have your cardiovascular system. You have your third spacing. I've mentioned this one, a drop in your blood pressure. And as a result, your negative feedback mechanism is to increase your pulse, PR. However, RBCs also drop, cardiac output drop, and then therefore you will have drop in your tissue perfusion. Okay? Lack of your oxygen. That's why some of the clients need to have your intubation for that matter. And then constant monitoring through your pulse oximeter. Next, for your respiratory, especially for your inhalation injury, yes, you will have your hypoxia. And then, as a result, your body would like to compensate to have as much oxygen. So, the body of that patient would have your increase in respiration. However, since there is also your inhalation injury and some of your anatomical structures in your respiratory tract is affected, you are going to have inflammatory areas there. So, possibly you will have your rhonchi, and some other scenarios you will have your fluid production already there, might have crackles, and then there will be decrease in ciliary movement, and then therefore you are going to have your airway obstruction. Next, you have your GI, as I've mentioned, because of your stress. The stress caused by your major burn injury would have an increase in your cortisol level, causing you to have a drop in your pH level in your GI system, so there will be hyperacidity. And then also, I've mentioned that because your sympathetic nervous system is stimulated, there is reduction of your GI motility, which likely would cause you to have your paralytic ileus, okay? Paralytic ileus. And then, in some other scenarios also, you will have your destruction of the lining of your GI tract, so you might have your melena as a result of your gastrointestinal bleeding, or you can have hematemesis as destruction of your intestinal, actually your esophageal lining, okay? And then you're also going to have an increase in your abdominal girth. For your urinary system, I have mentioned already that because your renal functions are likely affected, GFR, there will be an expected drop in your GFR. Filtration rate is very much affected because your kidneys have started to shut down. And if the kidneys have started to shut down, your GFR, the filtration will not be as effective as before. Now, as a result, your laboratory will show that there will be an increase in your creatinine because the kidneys are not doing its job properly of excreting your toxic substances. And then likely also you're going to expect that the patient is going to have your increase in your blood urea nitrogen, your increased specific gravity, and also your increase in your uric acid. You're also going to have myoglobinuria. It means to say the proteins have leaked out of your tubules, and then likely some of them have gone into your urine. So proteins are large molecules which should not be found in your urine. Okay, and this is because the kidneys have shut down. Okay. Next, we have your immune cells. There's going to be a drop in your T cells, dropped in your B cells, which are your very important lymphocytes, but WBCs are going to increase, proteins are going to drop down, phagocytosis will actually happen so that it can do some of the responsibilities of engulfing any untoward foreign bodies or substances, or even the dead cells that's happening the dead cells that's occurring in the burn area. Also, for your metabolism, there will be increased catabolism from your biochemistry lecture. Catabolism is the metabolism with less of your oxygen. So, there's a lot of your breaking down that's happening here. Anabolism also, really no oxygen at all. So, because the proteins are lost, okay, the proteins are lost, and there's continuous breakdown, you are going to have muscle wasting. Because there's no protein at all. Remember, proteins are responsible for building up your muscle mass. But because there is continuous breakdown and there's continuous loss of your protein, therefore, you're going to expect that the client will become thin. And the client will have your weight loss. And then, since again, there is continuous breaking down of your proteins, okay, you are going to also expect your acidosis and therefore hyperglycemia. So these are the things that are expected of major burn events, okay? Stages of progression, how do you manage it? From your emergent to your acute to your rehabilitative phase. For the onset of injury, okay, I've mentioned, if you are in the community, this is your first aid. Eliminate the burn source. Okay, this is in your first aid. Once you reach your emergency department, you, in the acute phase, are going to provide your fluid resuscitation. Okay, and then you have your ventilatory management, especially if you are handling clients with respiratory problems. And then you have your burn ICU. Okay, so these are the things that are expected management when you are in the hospital. And then you move on to your rehabilitative stage, wherein you have your long-term management, your long-term follow-up and consultation for that client until he achieves highest maximal functioning. Okay, so this is how you are going to manage your client who has your burns. Okay, then next we have the next part is your fluid remobilization or your fluid therapies. So usually it needs to your fluid response by the body, the changing back happens after 24 hours. So when the capillary leak stops, that's where edema fluid shifts from interstitial, from outside, going back into your vascular compartment. So blood volume increases, leading to increased renal blood flow, and your diuresis. The body weight returns to normal because some of the fluid has already gone back. Okay, now let's move on to the pediatric considerations when it comes to your burn injury. So for a client who is in the pediatric range of ages, so we are going to consider that the skin is very thin and there is increased severity of the burn injuries because, surface area is very, very large. Okay, and then you also have to think that for kids and for infants and for babies, they have very poor immune system because they are not yet well developed as with your adult patients. And then also we have very small airways when they are exposed to these burn injuries or burn inhalation injuries. Their anatomical structures cannot actually take in the destructions that's happening there. It's too overwhelming for them. So there is limited respiratory reserve capacity. And then likely another concept that you have to understand is that burns episodes in clients, pediatric patients, might be a possibility for abuse. That's why as a nurse, if you're going to do your evaluation, you need to ask the right questions. Okay, next we also have we have your geriatric considerations. So the very young and the very old are to be given appropriate considerations here. Again, their skin is very thin and there is poor circulation already owing to the effect of the wear and tear. There's deterioration already of your integuments there. And then you also have to consider that most of our elderly clients have your underlying disease processes. So they have your secondary morbidity aside from the burn injuries. So the most common affected ailments are your pulmonary and your peripheral vascular diseases. Also, you have to understand that the elderly client might have decreased cardiac reserves. That's why most of our elderly patients have, cardiac problems. And then again, you also have your decreased immune system because again, owing to your deterioration of your client's immune system. The percentage of mortality of geriatric patients is equal to the BSA that is burned. So age plus the percentage. So the more severe the client's burn is, the more possibility that the client will actually die if no immediate interventions have been provided to your client. Okay, so as a nurse, what do you need to do? First aid, stop the burning process. Okay, remove the patient from the source of the injury. There's a fire. The client is inside a house which is on fire. Remove. Okay, or if the patient who is hospitalized is in the area or the unit which is burning, remove the patient. Or you can remove the clothing unless it is stuck to the burn. Do not forcibly remove an already burned clothing and it's already attached to the skin. Okay? Other than that, you can easily remove the burning cloth. Okay, next is cut around the clothing stuck to the burn and leave it in place. So this is how you stop your burning process. Okay, so as healthcare fire safety, there are 4 essential steps that you need to consider, and we call it your RACE, R-A-C-E. So the first thing is, as I've mentioned earlier, remove the patient from the source of the burn. So R means to rescue anyone in immediate danger of the fire. Next, A is to sound the alarm. Activate the nearest fire alarm and call for your fire department so that they will know what to do. They will facilitate the stopping of the burning process. Or you can have letter C, contain the fire by closing all doors in the fire area. And then letter E, you extinguish small fires. Do not even attempt to extinguish very huge fires. You are just going to end up injured yourself. So for small fires, which is manageable, you do your extinguishing. Okay, if the fire cannot be extinguished, leave the area. Do not be a hero and close the door. Okay, that's what you need to do. Never mind the things or the belongings that are left in the area as long as life is preserved. Okay, so you should know the locations of the nearest fire extinguisher and the alarm pull boxes where they are located. You should also know the fire location, the room number, and the building, so that when the fire department would come, they would ask questions, you know what to relay to them. And then also all fire exit, you have to know where all fire exits in your work area are located. Okay, next. So as a nurse also, you need to once you have removed the client from the area of burn, or you have already started your assessment, you check for your ABCD. Okay, usually in this case here, assess for your airway and your breathing. So start oxygen if, okay, this is an immediate concern that you need to provide intervention stat. So if you are handling a client who has your moderate or critical burn, there is decreased level of consciousness. The client is not alerted to time, place, person, or event. If there are signs of respiratory involvement, you can see that there is shallow breathing, there is fast breathing also, there are crackles, there are rhonchi, and then also you have the burn occurred in closed spaces, or there is history of your carbon monoxide or smoke exposure. Then immediately as a nurse in the emergency department or in the burn area, you provide your oxygenation stat. Okay, next, assist ventilation as needed if it is deemed important that there is already your respiratory involvement. You are going to be on standby. So as a nurse, what do you need to do? You prepare all your equipment for your ventilation and your intubation. Okay, next, assess for your circulation. So AB, that's your airway, breathing, and then we go to your circulation. Letter C, check for your shock signs and symptoms. Remember, your hypovolemic shock. Okay, early shock seldom results from effects of burn itself. Early shock equals another injury until proven otherwise. So usually it happens at a later date. The manifestations become more apparent after a few hours. Okay. Next, obtain history. How long ago did it happen? Remember, the concept of your fluid resuscitation and replacement, it needs, the computation should start from the time that the client experienced the burn, not the time that the client was admitted in the hospital. So therefore, it's one of the basic questions that you need to ask your client. How long ago did it happen? What has been done? What are the interventions, first aid, procedures or measures which were done to the client? What caused the burn? Remember, there are different types of the causes of burn, and was it did it happen in a closed space or enclosed area? Was there loss in consciousness? Was there changes in the levels of consciousness? What are the medications which the client had, or were there allergies, past medical history? This needs to be interviewed. If not for from the patient, at least a significant other, okay? So that we would know what we need to do, so that we would know which medications we would provide to your client, which alternative treatment should be given to our client. Okay, next one is do your rapid physical examination. So check for other injuries, rapidly estimate your burned area. You know already what to do with your TBSA. Okay, check for the unburned area as well. Remove constricting bands because there would be obstruction in your perfusion, or you don't want add insult to injury. And then last but not least, you have to treat your burn wound. So do not apply ointments or creams unless prescribed. Usually, as Filipinos, what do we do when we experience burn in our hands? What do our parents usually tell us to do? You put toothpaste, which is a big no-no. You don't do that, guys. Okay? Sometimes the uneducated individuals do not understand the consequences of what they believe is true. So in this specific management, do not apply ointments or creams unless prescribed. So the drug of choice, by the way, for burn injury is your silver sulfadiazine. Okay, and then also for your superficial burns, like for example, your first degree burns, what do you need to do for that? You put your cool, moist dressings. Or I have friends who suffer from sunburn, and then they just buy your aloe vera, okay, aloe vera gel, and then they put it on the affected area. And then also you need to protect from exposure to the air because it's very painful. So for partial full thickness degree burns, it is very important that we need to cover it with dry dressing. We have commercial burn sheets which are acceptable for this. And then you need to go to the hospital for this one. So how do we treat your burn wound? See, this is your dry dressings. We need to follow strict aseptic technique, because there's a lot of entry points for your microorganism and don't want infection to set in. Okay, so we have here your minor burn dressing. So that's how it is done. See, all interventions are with the use of your sterile gloves. Okay, and then next we have this one, your sterile gel soak burns, especially again for second and third degree burns. So, and there's another one, it's still a gel. Okay, that's what it looks like. So it facilitates your it stops the burning process, and it cools down the burn. Okay, burn sensation, painful sensation, and it prevents your constrictions also. And then we have here, it's quite interesting. I've researched on this one. I mean, I saw this one on Discovery Channel before, and then I tried to research on this one, and this is the scales of your tilapia. Not the scales, but I mean the skin, okay, fish skin of your tilapia, okay, which is very much endemic here in the Philippines. We have so many ponds of your tilapia, okay, but please do not assume that that is the fish skin from the fish which is just sticking out of the pond. No, there's a system there. By the way, this is an unorthodox management of burn injury in the Latin America, specifically Sao Paulo, Brazil. They have come up with this system because initially there were already existing system. There were already existing use of frozen pig skin or even human tissue, okay, that is placed on your burn injuries, okay, already existing. But I haven't seen that one being done here in the Philippines. But there are already existing frozen pig skin and even human tissue, which is placed on your burn skin to facilitate and promote healing. Now, those type of management are actually very, very expensive. So, this group of researchers in Brazil have come up with the use of this fish skin, tilapia skin. Okay, and this tilapia skin, according to them, is very cost effective. It doesn't need to, the patient doesn't need to spend so much on that, on the treatment, because it lasts longer in the pack. And then you have to understand that these ones are sterilized, by the way, okay? These are actually sterilized, okay? So that's how it looks like. So we have here a picture of a client who had that tilapia skin. Now, what is the purpose, by the way? Why did they choose the tilapia skin? Tilapia skin, according to them, has high moisture, and also facilitates your collagen, okay, production. And then there is also, it is disease resistance, okay? It's disease resistant compared to the human skin or the frozen pig skin, at levels which are comparable to human skin. So tilapia treatment can actually, according to them, speed up your sensation of rehabilitation, okay? And it also speeds up healing by several days, and it reduces the need for pain medication. Remember, especially for your second degree burns, it's very, very painful. Okay, very, very painful. So, in order to facilitate your healing process and to have a cost-effective measure, they have decided to do this one. See the difference there? You have your tilapia skin for a period of 10 days, if I'm not mistaken. Yes, 10 days. Okay, and then after 10 days, this is what it looks like. So, see the fast healing process that's actually happening there, and at the same time, you don't need to use your dry dressing. Okay, sometimes you have to understand, this is an open wound. When you have your extensive burns, it's an open wound. And in order for you to protect your patient's wound, you need to cover it with your dry dressing. And imagine how you do your wound dressing. You need to change it every day. So imagine the pain that the client would have to go through and experience every single time you do your wound dressing. That is very painful. So instead of having to change your dressing frequently, this is what they did. Okay, the tilapia skin stays in your skin or in the affected area for 10 days. Okay, there is no additional cream. See, no medications. You just need to cover it. Okay, you just need to cover it with bandage, okay, and then remove it after 10 days. Okay, and then you have to also understand that this is free. Okay, the tilapia skin is free from any type of infectious process. The virus is actually sterilized. Yes, it is supposed to be sterilized, and it is treated. Okay, it is irradiated. There is your system of radiation on your tilapia skin to kill the virus and other pathogens before it is going to be packed and placed in a refrigerator. Okay, and once these tilapia skins are packed, they can last up to 2 years. Okay, they can last up to 2 years. So this is quite an unorthodox way of managing your burn wound. Something that is, very interesting for many Filipinos, because we have these resources already, but I'm not so sure if researchers in the Philippines will agree to that. But this has been a practice already. I think it has gone on for years, 2-3 years already, even longer than that. Okay, so I think that ends our discussion for burn. And if you have any questions, just post them in our Google Classroom. Good day, everyone, and have a wonderful day ahead of you. Thank you very much.